Welcome to another virtual shouting session at Hearts for Health, y'all. We're excited to have you here on this Thursday evening. For those who are in America, we hope y'all enjoyed your 4th of July. It's good to have a holiday here and there. But for this session, we're going to be joined by Malaika. She's a PA practicing trauma surgery in Canada. We have quite a few PAs over the past few weeks, and we'll be having a couple more going into this week and next week. So for those pre-PA students out there, this is your time. These are the sessions for you. I do have a few reminders though for y'all, especially if you are new to our program. So at the end of each of these sessions, we do have a Q&A, and we have a chat box either to the right or to the bottom of the live stream that you're viewing right now. Feel free to type in any questions that you have for Malaika or any future speakers that we have along our way. And we'll get around to those during the Q&A at the very end. I'll just read them out in the order that we receive them. And while we're at it, if y'all want to just type in where you're coming from, what state you're from, what country you're from, etc., in the chat while we're at it. And then my last reminder is for those who would like to stay tuned with virtual shouting sessions in the future, we do have 2 ways you can go about that. Either our Instagram page, which I'm sure many of y'all have found out about this session through, or our email listserv. And that email listserv is something that you can subscribe to on our website. If you go to the bottom of any of our website pages, you'll see a subscription form, and that just includes your name, your email. Send it over and you'll be good to go. You'll receive a weekly email, usually sent out on Thursdays, and that will include the flyers that we have along with a couple other opportunities if those are available. So we might have, and we will have actually, a few mentorship opportunities and also volunteering programs going on later in the fall. We'll release those details and the application links for all of those programs around late July to mid-August, between that time period. But if you have any questions, or if you're having trouble with subscribing to the listserv, if you're not able to navigate where it is, feel free to just email us with your name, your email, or whatever question you might have. Our email is community@hearts4health.org. Again, we're happy to answer any questions. But with that said, Malaika, feel free to take it away.
Okay. Hey guys, my name is Malaika. I am, like Michael said, a trauma surgery PA. I work in a level 1 trauma center in Toronto, Canada. We are the only level 1 trauma center that is acknowledged by the American College of Surgeons, and we recently got verified, so that's really exciting. And today I'm just gonna go over my pre-PA journey, along with my PA journey, and go over a few cases with you guys on what I do on a typical day in trauma. So in terms of my PA journey, actually PAs are not a really well-established profession in Canada. It's still growing in comparison to our colleagues down in the States. So coming across the word physician assistant, physician associate was really not well for me. Like most students in high school, I was very keen on studying biology or something to do with the human body. And the first thought was, oh, medicine. And then when I got to first year of university, I realized that, that's a pretty long career ahead of me, and there's a lot of moving parts to it. So I started to really ask myself, why MD? Why not other healthcare professions? So first year of university was kind of just me exploring different areas of medicine, nursing, OT, PT. I also wanted to look into research and whether that's something that I would personally enjoy. So a lot of exploring. And then randomly one day, I got an email about an open house information session about the physician assistant program. We still call it physician assistant here because we haven't had the name change at my university. And I was like, that's interesting. What is a physician assistant? I've never heard that before. But I quickly deleted the email because it said that you needed at least 2 years of undergrad and all of these other prerequisite courses. I was still in my first year, barely passing chemistry. So I was like, well, this is not for me. So moving on. And then first year happened, we moved on to second year. And that's when, for some reason, that like the word PA kept creeping up in one way or form or another, through information sessions, me seeing the department or passing by it. at my university, and things like that. So I started to do a little bit more research, and I was like, what is this PA thing? Like, why haven't I heard of it before? And I started to do a lot more research and learned that, it's very popular in the United States. So slowly, and at this point, I was also pursuing like other ideas, like, okay, nursing may not be the right fit because I don't really like shift work, OT, PT, I'm not getting the like satisfaction I want with direct, medical experience, etc. So I kind of started to really zone in on this PA role because it's like MD is pretty long. It doesn't really align with, my own professional goals and values in the long term. So maybe PA is the route for me. So then I was like, might as well apply to the PA program at my university. So there's actually only 3 PA programs in Canada. And maybe if I hadn't gone to the university, like the one university that does offer the program, maybe I wouldn't have come across it. So I was like, okay, let's just try and apply for fun and see what happens. I obviously didn't get in because I didn't take my application seriously, and I wasn't really fully 100% into going into PA school. I was just trying to like test the waters and see what is the application like. And then I think by the end of second and even third year of university, I was like doing a lot more research, and then I realized, no, actually, I really don't think MD is the route for me at all, and I really do want to pursue PA school. So then that's when I started to get more serious, making sure I get all of my prerequisites, healthcare experience, getting information about the program through other people who have been in the program, and things like that. I applied in my third year, didn't get in. I applied to schools in the States as well. Got a few interviews, got waitlisted to one school, but no acceptances. And then by fourth year, I feel like I was more experienced in applying. So I realized, okay, these are the weaknesses in my application. This is what I need to do to kind of really get in this time. And then fourth year, I got interviews and got accepted to multiple programs, which was great and exciting. It was definitely, I felt like I was losing hope in between my third and fourth year, but I stuck by it and it worked out. So I then moving on to PA school. PA school is pretty tough. Like, they're giving you a lot of information at once. It's like going through medical school, but half the time. So I'm really grateful for the program that I was in because they were very supportive and welcoming. They always made sure that, they provided the right resources for you. And yeah, so then unfortunately, COVID started halfway through my clinical rotations. It was really strange because everything kind of just like no one in the world knew what they should do, right? So they just shut everything down, and then they sent us home for a week, and they're like, we don't know what's happening, but stay home. And then a week later, we're like, and I was in my obs gynae rotation at this point. We come back a week later and they're like, okay, you can go, but these are kind of the rules. You have to wear masks and make sure that you're not like in any procedures that could, expose you to COVID, etc. All of my rotations got flipped around because not everyone wanted to accommodate students anymore. So one of the core rotations that I had to do during my COVID it kind of fell in that COVID time was general surgery. And because they had to change things around, I actually never got to experience trauma. I only experienced the acute care surgical side. So appendectomies, cholecystectomies, that kind of stuff, which I enjoyed. But towards the end of the year, I was like, oh, I'm a new grad. I really want to make sure that, I have a broad scope of practice and keep learning as I'm transitioning into a provider role. So I prefer to stay in primary care or emergency medicine. So that kind of moves us on to my PA career journey, where I actually first started out in primary care. During that time, they provided a funding specifically because of COVID to kind of decrease the load of patients that are going to the emergency department and redirecting them to primary care for low-level COVID symptoms. So obviously, if you're not able to breathe, right, or you're elderly, or you have really significant risk factors, you'd be redirected to an emergency department. But, if you're young, you're just having flu-like symptoms and you need to be checked or you get a COVID swab, you'd be redirected into these primary care clinics. So I was hired to be a primary care provider in one of these clinics. However, as you can imagine, they're low acuity COVID patients. Really, when they come, you're just telling them to rest, making as long as they're not decompensating. If they're decompensating, I would say, okay, you have to go to emergency. But if they weren't, they truly was just resting, Tylenol, make sure that, you're having good fluids and stuff. So simple management for a viral infection. So it got really boring because there wasn't a huge patient load, and the management kind of got very repetitive. It was very niche if you think about it. So what I asked my supervising physician was, hey, I have extra time on my hand. You're paying me anyways to just twiddle my thumbs, basically. So can I see some of your patients? I could do an acute care, in Canada, it's really hard to access family MDs. Some patients have to wait 2 to 4 weeks just to have a routine checkup. So obviously someone who has a UTI and wants antibiotics right away and is not going to wait 2 weeks, they have to go to unfortunately, the emergency department or another urgent care clinic. So instead, we kind of use me as the urgent care setting where, if a patient that already existed as part of the clinic needed to have needed to be seen more urgently, I would be able to see them and then review with the supervising physician. So that model kind of worked really well for me because I was still kind of doing my actual job, what I was hired to do. But I also got to, continue transitioning into my role as a provider and, do more urgent care clinic type of stuff and not be bored at work. I actually moved out of province in order to train to go to PA school. And I wanted to come back to Toronto because that's where I'm originally from. However, due to the different funding models, which I'm not going to get into too much detail, in Canada, I needed more experience to be able to apply to jobs in the Toronto region. So that 1 year of experience in Winnipeg really helped me gain that edge that I needed in order to apply to jobs in Toronto. So I had originally applied for an emergency PA role at the hospital that I currently work in. And unfortunately, halfway through, it kind of fell through the crack, not halfway through. The day before I was supposed to start, it fell through the cracks. There were some sort of internal issues that were going on in the hospital. And they said, don't worry, just show up. We're going to figure something out. In the meanwhile, we'll keep orienting you and we'll figure out what, we're not going to leave you hanging. So I was like, okay, sure. I had to have a lot of faith. And then eventually they said, hey, we're looking for a trial role in the trauma surgery department. They've never had a PA there. Is this something that you'd be interested in? And I was like, no, I don't think so, because I don't even know what trauma is. And this kind of goes back to that story I was telling you earlier about, because I was a COVID cohort, I didn't experience all of general surgery, and definitely trauma, I didn't see at all. So they said, don't worry, just talk to the chief surgeon and then you don't have to make a decision now. So I was like, okay, sure. So I go to the chief surgeon and he's like, it was basically an interview, but I didn't really realize it was an interview. And he's like, so what do you know about trauma? And I was just like, nothing, absolutely nothing. But I don't know. So something in him saw something in me and he's like, don't worry, you'll learn. And I was just like, okay, sure. So then I was like, let me, shadow a lot of people in the department, make sure, this is the right fit for me before I lock myself in. And, I really got to see okay, this service is struggling in general because there really is no continuity of care. And a PA's role perfects this service because I'm doing exactly what I need to do in order to help with the healthcare system. You know, I'm flexible. I can fill in the gaps wherever needed. The residents are turning over every 4 weeks. The attendings are turning over every week. So there's just a lot going on this service, and there's a high volume of patients. So if like, I was kind of shocked at this point, and I was like, I'm surprised that they never had a PA before, you know, like, why is it suddenly becoming, like, why are they trialing it now? They should have trialed it many years ago. But anyways, so that's how I ended up in the trauma surgery role, which I'm currently in now. It was definitely like a leap of faith, and, you know, figuring out like, is this going to be right for me or not? And it did end up working out, which I'm really grateful for. Yeah. So what is trauma? For those of you who don't know, trauma surgery or trauma is basically patients who have polytraumatic injuries. For example, gunshot wounds, motor vehicle collisions, elderly people that are falling from, and they're really frail, so they can get a lot of injuries from that. People who are walking across the street, get hit, you kind of get the picture. So people who have a bad collision or whatever and end up with more than one injury, end up coming to a trauma center. And what is a trauma center? So a trauma center is basically a hospital that is recognized to resuscitate patients that have polytraumatic injuries. And they really have all of the resources and the specialists that you need in order to be able to manage these patients. So, for example, if you live in the middle of nowhere and you get into a motor vehicle collision, you're going to likely go to your nearest emergency department, but your community emergency department probably does not have a CT scanner. They probably have X-ray techs that you have to call in and say in the middle of the night and say, you have to come in. They probably don't have blood products. So they don't have the resources, and they probably, like, for example, if you have a brain injury, they probably don't have a neurosurgeon. So all of these special things are found in a trauma center. So my role as a trauma PA is to basically help with the entire trauma service. So when patients come, their typical trajectory is they'll have the injury, and from the point of injury, they'll be brought to their nearest facility to be stabilized. For us, sometimes they come directly from the scene. Other times they're flown by the helicopter. Other times they have a little gateway stop in a small emergency department, are quickly stabilized and then transferred to us. They come in, and then in this picture, you can see a typical trauma bay, and they're resuscitated here. So we'll go through the ABCs of trauma. So make sure, you know, their airway is patent, they're able to breathe, their circulation is good, pulses, you know, all of the things that are life-threatening are addressed in this stage of their trauma care. Once we've stabilized them, we kind of decide, okay, is this patient stable enough to go to the CT scanner where we can further delineate what other injuries they have, versus, is this patient really sick? We've only stabilized them for a few more minutes, and we really need to go to the operating room to fix whatever internal injuries they have. So that's the decision that we make in the trauma bay. And then after that, once we've figured out all their injuries, they've been operated on, they will go to the ICU if they're really critical, or they'll go to the ward, wherever. Eventually, they'll make it to a bed, and they'll continue to be managed medically. So typically, as a trauma PA, I can be seen in any parts of that journey. The only part that I personally don't participate in, not because I can't, but because I choose not to, is being in the operating room. And the reason for that is because we are, again, a very big trauma center. So we have a lot of learners, and for me, it's not the best use of my time to be in the OR when there's a lot of learners who want to learn how to operate, and I can be, my expertise can be used elsewhere in the hospital. So, but I will be involved in resuscitating the patients in the trauma bay. I'll be helpful and help the staff being oriented to all of their patients. Any issues that come up, I'm really helping coordinate the logistical aspects of patient care, writing discharge summaries, and then orienting the residents so that they know, okay, what is expected of them, helping them learn procedures like chest tube insertions and removals and other things like that. yeah, and then a lot of like ward management, if patients do crash, making sure that we're there and leading the code, making sure that anything that needs to be moved along for patients in terms of medical care, we can do that. And then a lot of family meetings, because residents typically are busy with academic days or they're busy with the trauma. So, and obviously patient families are really worried, their family members are really sick, and they need that reassurance from a medical provider, which helps in terms of my role because I'm there, continuity of care. I typically know what's been happening to this patient since day one. So I can kind of fill in the gaps for the patient's family. Okay, so I'm going to go into the cases. The first case is a stab wound. So a 15-year-old male, he had a stab to his back. He had 2 wounds to his right chest. And that's kind of the handover that we got from EMS while he was being brought in. So you can kind of imagine like Grey's Anatomy, but less dramatic. So then when he comes into the trauma bay, the goal is to resuscitate him and make sure we stabilize him. And the main trauma bay interventions that we introduced was a chest tube. So a chest tube, as you can see in this picture, it basically helps evacuate any air or blood from the chest in order to help the lung expand. And that's a common problem with someone who gets stabbed to the chest because it can easily puncture the lung, causing air to leak, which then causes the lung to collapse. He was considered to be stable otherwise, and then he continued his course in hospital until his chest tube was removed, and then eventually he was discharged home. So this one was a pretty straightforward one because he was young. It was a penetrating injury. It was localized to one area, and we didn't really need multiple interventions. Okay, so in the second case, we have an elderly female, 94 years old, who had a fall from standing. And a lot of people actually who don't practice medicine get really shocked when they hear that, a patient got this many rib fractures when they fell. So people really underestimate how frail the elderly are. So they can actually get really, really bad injuries. Even I've seen really bad injuries just from like someone sitting in a wheelchair and falling over because they just don't have the same resilience that younger people do. So the other thing about the elderly is that they have a lot of comorbidities. So when they do fall, we have to figure out why did they fall. So this patient fell because they had an underlying heart condition called atrial fibrillation. And when they got to the trauma bay, we were told that they have a GCS of 3. And GCS of 3 basically is how we quantify our neurological exam. It tells us, if the patient's able to move their limbs, move their eyes, respond to commands, are they talking to us? A GCS of 3, like even a rock could have a GCS of 3. It means the patient's not doing anything. They're not responding at all. And when someone has a low GCS in the context of trauma, the first thing that really comes to your mind is, are they bleeding in the head? So in this picture, you can see a CT scan of a head, and it shows some intracranial hemorrhage. I don't know if I can. Okay. If we see that bright white dot in the middle, there's kind of a line going in the middle of the head, and you see a shift of the brain. That's what we call a midline shift. And it basically is showing us that, the blood is pooling and pushing the brain to the other side, meaning that, there's not enough space in their skull as it is. So it's trying to shift to make more space for the blood that's accumulating. So in this case, it was really important to have a goals of care discussion. And this is basically when you ask the family members, because obviously the patient's not able to be a part of this discussion about, what are how did this patient imagine their quality of life, and what would they want for them, right? Like, some people are very adamant that I would want you to do everything possible until the end in order to, resuscitate me and make sure I'm alive. But obviously other people, especially the older you get at 94, patients are like, no, if I'm not having a good quality of life, then let me go. There's no point of trying to continue interventions. So in this case, after having the goals of care discussion, we identified that, this patient wouldn't want any further interventions. So eventually they passed away. Okay. And then the third case is a gunshot wound to the head. So this is a 31-year-old gentleman, attempted suicide. And that's the handover that we got from the EMS. So when they were brought to the trauma bay, so this patient, the trajectory of the bullet was tangential. So that's why it didn't really affect them as much as you would think, because obviously when you think of a gunshot wound to head, you think, okay, you automatically die. That's not the case. So the CT head showed pneumocephalus, which basically means you have air in the brain, and the air pockets formed because of the trajectory of the bullet, and the blast component of the bullet. The patient was stable, and there was no significant brain bleed that needed to be operated on. So we just followed him with serial CT scans to make sure that the air in the brain resolved on its own. Obviously, this patient couldn't be sent home because their mental health was not great. So once we were done with their trauma care, we eventually discharged them to a psychiatric facility for ongoing mental health care. Okay, motor vehicle collision. So this is probably the most common, one of the most common that we will see in our trauma centers. So in this case, we had a 45-year-old female. She was in a motor vehicle collision. Restrained means that she was wearing a seatbelt. So if you're going to take any tip from me during this entire session, my pro tip is always wear your seatbelt. Like, it's a life-saving intervention. I cannot tell you the difference that it makes between the same people in the same collision. One was wearing a seatbelt, one wasn't. One walks out of the hospital 3 days later. The other one is with us for months. Okay, moving back to the case. So that was the EMS handover. A 45-year-old female, she's coming, she had a motor vehicle collision. Once in the trauma bay, we did our ABCs, which means, is her airway patent protected? Is she talking back to us? Is she able to breathe, right? So does she have good air entry bilaterally to her chest? Are her pulses good? Is her heart pumping? Is her heart rate okay? And is she bleeding from anywhere? So we always look for external sources of bleeding and internal. External is very obvious. We uncover the entire patient, expose them, make sure that, we're not missing anything. And then internal is other adjuncts. So we'll do a chest x-ray, make sure that there's no bleeding into the lungs. We'll do a FAST. So it's an ultrasound where it looks into the abdomen, the pelvis, along with the chest to make sure that they're not bleeding into any of those spaces. And then we'll do a Foley catheter or NG tube to make sure, they're not vomiting any blood and they're not peeing any blood. This patient eventually went to the CT scanner, and it was found that they had splenic laceration, small bowel perforation, spine fractures, pelvic fractures, humerus fracture, facial fractures. Basically, they had a pretty bad trauma. So this is more like the other cases that I presented were more like single system. So this is definitely a polytrauma. They were taken to the OR immediately for a trauma laparotomy to have all their abdominal injuries repaired. And then they were also taken by orthopedics to make sure that all of their other, like their arm, their pelvis got fixed as well. She was stable post-operatively, and then 2 weeks later was discharged. But obviously patients that have pelvic fractures or fractures everywhere and a prolonged hospital stay will get really deconditioned and obviously also need their pain managed. So eventually when they do need to go, they don't typically go home right away. They have to go to a rehab facility to work on, reconditioning them. Okay, so those were kind of the major case. I threw in like the most common ones, like fall from standing and a motor vehicle collision, and then I threw in like more interesting ones like the stabs and the gunshot to head. But I hope that was helpful in you guys learning about my PA journey, as well as what it means to be a trauma surgery PA in Canada.
Well, we love to hear it, Malaika. It was great to hear your journey, how you stumbled into trauma surgery, and also a couple of these cases here. I'm going to start it off with one question, and for those listening in, feel free to type your questions in the chat. But you mentioned that you practice in Canada, and the proportions in Canada at the moment are not as comparable to the US, right? You're more of a minority in general to the provider proportion in Canada, at least. So how would you compare the autonomy, though, between Canadian PAs and American PAs, to your knowledge?
I don't really know what the autonomy is like in America, obviously, because I haven't experienced it. But I mean, like in general, I do feel like they do have more autonomy. I also think for Canadian PAs, it really depends on that trust that you build with your supervising physician. So my answer may not reflect all Canadian PAs, but I definitely feel like I have a lot of autonomy in the place where I work. And it took time to build that trust. For the most part, so I work with 6 trauma surgeons. The first 5 were on board since within the first month. Like they saw that, I take initiative, I ask a lot of questions. I know what the limits of my knowledge and my scope of practice, and I'm not going to go beyond that unless I'm comfortable and they're comfortable with it. One of our trauma surgeons was a little bit skeptical, so it took her longer to be on board. However, now 2 years in, she's always praising, and she's just like, I'm so glad you're with us. Don't leave us. But definitely, I feel like, and that's kind of the unique role of PAs, right? Because we have supervising physicians, you really develop that trust with time. And the other thing that you also develop is clinical judgment based on what your supervising physician would like. So every time our trauma surgeon switches, I'll even be telling the residents, I'm like, don't do that, because the trauma surgeon's not going to like that. They prefer this course of action for this specific patient. And when you learn kind of those little nuances, you build even more trust, because they're like, okay, Malaika knows that this is how I like things to be done.
Another thing that I know happens in the US is residency for PAs, but it's more of an option. Is that the case in Canada?
We don't have residency options at the moment in Canada. I feel like it's something that will probably develop in the future as we become more established. But at the moment, I don't know of any residency programs. We only have 3 PA programs. Creating residency programs is top-notch, next level. We are in the process of creating 3 more PA programs, which is really exciting for us. So I think we'll get there one day.
And you went through a couple of these cases. You mentioned a couple of them were common cases or bread and butter cases. What other cases, or types of cases, I should say, can you think of that you often would see?
So most common in the summertime, people who are riding bikes and get hit by a car, pedestrians that are crossing the street that get hit by a car, motor vehicle collisions, and elderly people falling, And then, so those are kind of the bread and butter. But then we'll also see really weird ones, like someone paragliding and falling out of the sky, like it went wrong. Yeah. And then a lot of people get stabbed and gunshot wounds in the summertime because everyone's just out and about choosing specific, having choices that have consequences. Anyways, in the winter time, it kind of shifts because less people are out. So we have a lot of more like people who self-harm, people who get into bar fights. The motor vehicle collisions are just throughout the year. And then the self-harm attempts can range. Like it can be someone who jumps out from a building, someone who stabs themselves, someone who purposely jumps in front of a vehicle, moving vehicle, things like that.
And we know that along with being a PA and outside of being a doctor, there's some other routes, right? Either nursing, nurse practitioning, etc. Did you consider those routes? And if you did, what were your reasons for choosing PA over those?
So I think the main kind of what I narrowed it down to in terms of being medically involved with patient care, like dealing with treatment plans, as well as providing medications and direct patient care from a medical perspective, that kind of ruled out like OT and PT for me. So I was thinking MD, art, so respiratory therapy, physician assistant, and nursing. Nursing, I wasn't a big fan of the shift work. So that's why I kind of put that onto the side. Respiratory therapy, at the time, I was also looking into physician assistant. And because when I compared the two, I was like, PA just stands out more to me because I feel like I get to do what an MD would do, but not necessarily have to go through that long route of training and, all of the financial aspects and life planning that comes along with such like doing schooling for so long.
So we know that you can do trauma surgery as a PA. What other surgical specialties can you do in Canada as a PA?
I think almost anything. So in my hospital, we have oncology PAs, we have an orthopedic surgery PA and neurosurgery, plastic surgery. We have the general surgery, acute care. So at our hospital, because we get such large volumes, our general surgery is split into half. We have trauma and then the acute care. So there is a PA who works for the acute care side. What else do we have? Those are like mainly the surgical specialties, but we also have PAs like in the emergency department and clinics and elsewhere. So I feel like, honestly, I think the most popular places you'll find PAs are in surgical specialties. And then after that, it's like emergency and primary care.
Early on, you mentioned that you had a couple application cycles before finally reaching PA school. And in that, you applied to a couple American programs. What was your experience applying to American programs as a Canadian student?
It was kind of hard because I didn't really understand what it meant to apply as an international student. I kept thinking that, it's going to be the same as applying, like as if I'm an American. But I realized through the application cycle that, I'm not competing for like the 50 spots that are available. I'm probably competing for a few spots that they've reserved for international students. And then it was also a little bit more, you had to put a little bit more into your application because you have to convert all of your GPA through WES. You have to make sure that, each program, you meet their requirements. And the American requirements are a lot more, every program is very, very different. Like, a lot of them don't even have the same entrance exam. Some of them require the GRE, some require the PA CAT. So I think there's just a lot more research involved in applying to schools in America.
Another question we have on that same line of thought is, if you now, as now a practicing PA in Canada, would want to practice in America, is there a defined pathway to do that?
You can. As a Canadian trained PA, you cannot work in America, but the other way around works. So if you're American trained, you can come to Canada. Currently, the American College of Physician Associates says that in order to write the PANS, you have to have graduated from an American school. So we can't even write the national exam. We'd have to go back, we'd have to go to America, train there, write the exam. I know that they're in the talks of trying to like find an equivalency and allow us to write the exam. So that's something I'm looking forward to see in the future. But at this time, if you are an American citizen, considering applying to a Canadian PA school, that's something that you should know.
Definitely good to know. And also something that you mentioned in your journey earlier on is that PA school in a way is like 2 years of medical school, right? I'm sure your study strategies shifted with that level of intensity. Could you go through a little more detail on that?
Outside of all of the mental breakdowns, I think the first term was pretty soft for me because I went to a pretty tough university to begin with, and our first semester was covering more of the basics, going over anatomy, physiology, biochem, all of that stuff. It's the second semester that really killed me because that's when we started our clinical based knowledge, learning about cardiology, learning about internal medicine, whatever. And at that point, my study strategy that I was just using the same strategy I was in university. It was not working because number one, there was way too much information for the amount of time we had. And number two, you kind of want to take away the main pearls of how you would manage a patient. And it's really hard to conceptualize that until you start seeing patients in clinic or going into clinical rotations. Because once you're a PA or in clinical rotations, you're like, oh, this is probably how I should have studied. It would have been easier. However, hindsight's always 2020. And even if I explain that to a PA student right now, it's just so hard to really fully understand that and also let go of your previous studying habits, which obviously were so successful and got you here this far. So after a few mental breakdowns, then I learned that, I need to just focus on the major big picture, and anything that I can't learn sucks for me. I'm going to go write the exam, try my best, and then move on. And I honestly I like that approach. So going to third semester, that like I kind of got into a good mojo, and I was like, okay, this is working. It's fine. I'm not going to be like the perfect student, and I don't need to be. I just need to understand, what are the major big pictures. And honestly, once you get into clinical rotations, everything starts to make so much more sense because you see a patient that's live in front of you. And then when you touch their ankles and you're like, oh, this is pedal edema, you will never forget it, right? When you're kind of just studying and memorizing your notes, you don't fully grasp that, right? So clinical cases really do stick with you, and you'll have your first of everything. My first pedal edema, my first CHF exasperation, my first pneumonia, my first trauma case, right? And then you'll know, okay, this is the general approach I want to take. These are kind of my options in terms of what trajectory my patient will go into. And then you kind of learn about the art of medicine too, because there's the science, what you'd want to do, but there's also the art, taking into account, who is my patient? How old are they, right? What was their previous health like? What do I need to keep in mind when I'm treating them this time around?
Heading out of PA school, what would you say that employers look at most, or what sticks out to them from your experience when you're seeking out a job?
For new grads, I think the most valuable thing you can show is that you're willing to take initiative, ask a lot of questions, and be a team player. And this goes for any job really, But the last thing you'd want to do is hire someone who thinks that they're a know-it-all, overconfident, not willing to learn, not willing to be a part of the team. Like, that's not something you want. And especially as a PA, like, your role is to help your team members, be that continuity of care, fill in the gaps in the healthcare system. How can you really, fulfill that role if you're not collaborating with all of your team players, whether that be the surgeons, the residents, the allied health team? So I think showing that, I will take initiative, I will collaborate with others and continue to work on building my knowledge. Those are all really valuable traits, and I'm sure anyone would want to hire you if you embody that.
And then for any Canadian pre-PA students listening in, like you said, that there's not many PA students in Canada. So how would you recommend that they get in touch with PA students or practicing PAs for mentorship purposes?
My pro tip is use LinkedIn. It doesn't hurt to find your local PAs in the clinic, in the hospital, and just shoot them a message and say, hey, my name is XYZ. I'm on my pre-PA journey. A brief introduction about your little education background. I'm really looking for opportunities to learn more about the PA role. If there's any observership opportunities available, please let me know. That's at least how most people get their observership roles with me. My kind of outlook on that is, you're not, like, the worst thing that could happen is they don't reply or they say sorry, no, but at least, you tried. The second way you can do it is identifying PAs that are in the community and cold calling clinics. Try and speak to the manager and say, hey, introduce yourself. I'm really looking to get more experience and mentorship from a PA because I want to apply to PA school. Is there any opportunity like that available? And you could also do that for hospitals, although hospitals are a little bit bigger, so it might be harder to kind of cold call, because you need to know exactly what department to reach. And I would also go to a lot of open house information sessions for whatever PA programs are there. The great thing is a lot of them are virtual now because of COVID. So you can really network with like PA alumni or people who are faculty in the PA programs, and they can also provide opportunities.
Looking back at undergrad, is there anything that you would have changed about how you went through it?
I would have cried less. I think I was a bit hard on myself, especially with the rejections. But the funny part is, you kind of lose sight as time goes on. The funny part is, when I first started applying, I told myself, I was a Malaika, you're just applying to get a feel of how it's going to be, so that eventually when you're ready to actually apply, you know how to do it and you have a better chance. But through the process, writing the GRE, of like doing all this research, applying to programs, writing personal statements, I kind of lost that initial vision. And I think the rejections really did get to me. So third year was pretty tough. But, I think you need to surround yourself by supportive people who remind you, like, it's really not the end of the world if you do get a C on your transcript, right? You're all a human and you work with the resources, time, and like whatever is available to you, right? And as long as you try your best, that's what matters. And there's also no limit to time. I think the other thing that was stuck in my head was, oh, I have to, graduate by this age. I have to finish PA school by this age, And looking back at that, I was like, there really was, like, I was walking around as if someone had a gun to my head saying you have to finish things, but it's truly not like that. Like, everyone's journey is different, and you should just relax and take it as it is.
I think of all things, extracurriculars can be probably the most unique, right? There's a lot of variety with extracurriculars. So with that said, what would you recommend to pre-PA students in general, whether from Canada or America listening in, as to maybe a couple examples of extracurriculars that they might be able to take on? Any tips of how they should go through extracurriculars? Sometimes I know people are a little passive with it.
I think that you should pick extracurriculars that you're passionate about. I feel like a lot of students get stuck with the idea of, oh, I need to have an extracurricular that's specifically healthcare based, and I can only have that on my application. But the reality is, no, you want to be unique, and a longitudinal and quality based extracurricular will stand out way more on your application compared to, I volunteered here for 2 months, and then I volunteered at this hospital for this 2 months, and then I volunteered at this clinic for a month, because what these experiences in terms of the extracurriculars is what's going to help you write about your experiences in your personal statement. So when you talk about, I don't know, playing the piano and tutoring or teaching little kids the piano for a course of 10 years, that's something that you can really talk about in your personal statement. And I think a lot of students don't realize that. They think that they have to stick to like medical topics. No, you don't. What you're trying to show is that I'm a person who's passionate. I'm a person who has good leadership skills, good mentorship skills. I am organized. I have good time management. I can do my schooling, chores, etc., and also tutor these or teach these kids piano, right? So these are kind of the skill sets that you can highlight, and that experience is meaningful, even though it's not healthcare related. So definitely choose something you're passionate about, have a longitudinal experience. You obviously are still going to get your healthcare experience in because of all the requirements that are required in the States. But again, try and make it a longitudinal one.
And of course, we can't forget the personal statement. I know a lot of students, whether you're a pre-PA student or pre-med student, pre-health in general, personal statements, they're hard to get the ball rolling with. So what reflections would you recommend that students think of, or what questions do you think students should ask themselves before they write a personal statement to get their mind running with ideas on what to write?
Yeah, I think you really need to know why you want to be a PA. And I think in order to get yourself thinking about it, you need to kind of get out of your head, like think about things that you're actually passionate about. Like, why do you want to help people in a hospital setting, right? People are sick. They're coming to you when they're at their worst. They're not going to be at their best behavior because of all of the pain or anxiety or whatever they're experiencing. So what is it about this profession that really makes you feel like you are resilient for it, you will excel at it, and you will create an impact in other people's healthcare journey? So those are the kind of questions that you should ask yourself. And don't get trapped into saying things like, I really want to help people. I mean, of course you do. I believe that. Everyone believes that. But it's not something that's going to make you stand out, right? What's going to make you stand out is your unique personal experiences, right? Again, it doesn't have to be healthcare related. But when you figure out like the core of why you want to go into healthcare, then you can draw experiences from your life to show that, this is what made me want to pursue this profession. I really do understand what this profession means. So make sure that you do research, like why is a PA different from an RT, an OT, PT, MD, etc. And highlight that. Say, I really know what I'm signing up for. I did my research. I know I'm passionate about it because of these reasons, and show examples through experiences of, what skill sets you've developed in your life that will help you continue or be excellent in this profession.
And just before we close out, we're almost at the end of the hour. Looking back on when you applied to PA schools, and even just now with what you might know about each program, especially in Canada specifically, how do you, or what ways do you see that they differ from each other and what they look for in applicants? And if you have any examples to go along with that, that would be great too.
the difference between Canadian and American programs when applying?
Well, more so how the difference within Canada as to what each program looks for. So I know that some places might have regional preference, and that's just something that you can't control. But for things that you can control, it's helpful to know, right?
Yeah. I think the main thing, main difference is healthcare experience requirements. I know that in America, like each school differs, but there's a lot of emphasis on it versus in Canadian PA programs, there's not really much emphasis on it at all. That being said, I do think having healthcare experience is really valuable because again, you want to make sure that this is the right profession for you, and you can really only understand that by being in a healthcare setting and seeing it firsthand. So that's one of the main things that's different. And then also Canadian PA programs don't have any entrance exams, so you don't have to write the GRE, PA CAT or anything. So that's kind of helpful too. I think the other parts are pretty similar in terms of applying. The other thing that makes it a little bit tough in Canada is because there's only 3 programs and each program roughly has an average of 20-ish students. There's just a lot more applicants compared to the spots that are available. So that part makes it a little bit tough.
All right. Well, thank you so much, Malaika, for joining us on this shadowing session today. I do have some last reminders just before we hop off for our shadowers. So we do have a quiz for y'all, and that quiz is now posted in the chat box, in the same chat box that we have questions for. It's also available on our virtual shouting page, and it's also in the video description, which should be under the live stream that you're viewing right now. So any of those 3 places have the same quiz link. It's a Google form, 6 questions or more, and you'll pass if you get 6 or more correct. And that will be due next Wednesday, July 12th at 11:59 p.m. Central Standard Time. Just be sure to get it done before then. And if you have any questions about if you receive the certificate or not, please do let us know. It should be sent directly to your inbox. It might send over to your spam. So just definitely check that in case you don't get it to your inbox. But if you don't have it sent to either, feel free to reach out to us. We're always happy to take any questions. And I mentioned this at the beginning, but let me mention it again. Our email address is community@hearts4health.org. Feel free to reach out with any questions. We're happy to take any there. And then for our next shadowing session, we're going to be joined by another PA, this time in emergency medicine and in orthopedic surgery, Arthi, and she will join us on Monday, July 10th at 7 p.m. Central. That's our normal time, 7 p.m. Central. And if you're new, we do have sessions on Mondays and Thursdays typically. Sometimes that does vary, but very rarely. So with that said, y'all can follow us on Instagram for more, on our email listserv for more. If you didn't catch the reminders in the beginning, but that really is all. Malaika, I also know that you have an Instagram handle. So if anyone wants to connect with you.
Yeah. Oh, for sure. So it's just at the trauma PA _. You can definitely check out my page. I do leave a lot of advice for pre-PAs in terms of applications and even PA students. So definitely check that out. And thank you so much for having me today. It's a great opportunity.
Of course. It's great to hear you. And definitely check her page out. Advice is always needed, especially when it's from a practicing professional. They've already gone through the whole process. So it's very helpful to hear that. But thank you again, Malaika. Let's hear some thank yous in the chat for her. And that will wrap it up. I hope all of y'all have a great evening.